Yes, thank you so much. And hello, everyone. I'm grateful for the opportunity to be here today and to share with you ways to appreciate and care for birthing parents with substance use disorder and for their infants. As part of the Swedish addiction recovery team, I'm grateful to offer comprehensive services to marginalized patients with substance use disorder. This continues to be a meaningful experience that pushes me to grow while teaching me humility and humble spirit for every outcome I witness. I'd like to start with gratitude and acknowledge all of you, wonderful nurses, as amazing healers, mentors, and caregivers. Participating today in this presentation is also a way to support and to help with discussing substance use in pregnancy and opportunities to help with care to birthing parents, newborns, families, and hopefully making it more approachable for you. And on the next slide, you can see a beautiful photo of Miss Masita Mahanji, who is a proud woman in recovery. For the past 3 years, she has been the face of the governors in the Washington Opioid Task Force, and she has a passionate voice to advocate for improving services for women with substance use disorder. Masita, I'd like to say thank you for agreeing to be here today, and also I'd like to ask for your permission to help me present and to allow you to introduce yourself to the audience.
Mm. Yes, thank you for having me. And I am very humble and excited to be here. And my name is Nasitsa Mohanji, and I am a proud woman in recovery. And that is my daughter, Nala. She is 3 years old as of today. And I just want to continue to advocate for healthy mothers and healthy babies and to break the stigma and to really just, preach about compassionate care. And I'm so excited to get to do that today. Thank you for having me.
Thank you, Masita. The next slide shows that we have no disclosures and our objectives are already outlined. And then we want to start with talking about myths and truths for substance use disorder in pregnancy. And I'm going to ask you to move to the next slide. The first myth is that addiction just happens. We are bombarded with social media on a daily basis, given that impression. The World Health Organization and ASAM, which stands for American Society of Addiction Medicine, define addiction as a chronic and treatable brain disease that is directly connected to how people engage in compulsive and harmful behaviors. This slide also, as you can see, presents information on the data of opiate use disorder for birthing parents and how it directly impacts women. Masita, what thoughts come to mind when you see the data on the slide? Can I ask?
Yes. Thank you. Yes. I'm just looking at it, and I know for me, addiction did not just happen. There was a lot of things that went into it prior to me using, like had PTSD, and I had a lot of trauma and stigma. And just looking at those numbers, it's very shocking to see, but I know for myself personally that a lot of things led up to me using, and just having a lot of that fear, and I had a lot of judgment and a lot of stereotypes. It just everything in one led up to me using. So it's really interesting to see the numbers on the screen.
Well, thank you for sharing and thank you for your courage also to be vulnerable today. And as we can see, we also live in a world where we see fentanyl and how synthetic opioids directly relate to deaths in women. And the next slide also connects to stigma and racism as two other pandemics in addition to the opioid. That's the that thing about stigma and addiction that kind of, just connects and allows us to appreciate it every day. Stigma can be defined as labeling, stereotyping, separation, and discrimination in a situation where power is usually exercised. We can appreciate how past stigmatizing attitudes, lack of provider skill, and empathy can compound a using patient's feeling of rejection and isolation, which contributes to stigma. And stigma represents a real barrier to treatment. It results in poor quality care, negative maternal risk, and fetal and newborn harm. We face also social and racial disparities, as you can see, that further contribute to discrimination and negative attitudes. Masica, can I ask you to share your experience as a Black mother and how we can improve racial disparities? And you speaking as a person in recovery, how do you think you can teach us to do better?
Yes, as a woman of color, and also I was, addicted. I felt like I had all three things against me. I was like, okay, I'm a woman of color. I was addicted. I am pregnant, and I really felt like I had nowhere to go. I felt like I had no, help. And honestly, what made it better when I went to the Cubs program was that they looked past all of that, just looking past the color and looking past, my gender and why I was there. They did not judge me and did not have any judgmental feelings towards me. So being respectful, treating me like a human being, and looking past all of that stigma, I felt welcome and I really felt like I could trust. And that's a big thing is wanting to trust your provider.
Masita, thanks for sharing. And even the next slide, if we can advance it, can talk about everything that you reflected on, the fear, the discrimination, the barriers to care. You also shared with us how important it is to have trust, to feel non-judged, and to receive racial and equitable care that is also very respectful. And if we advance the next slide, we will talk a little bit more about mental health, substance use, and maternal mortality. There is such a strong relationship between all of them, in addition to maternal and neonatal mortality. You can see that 1 in 5 birthing parents will experience mental health or substance use problem during pregnancy and postpartum. In addition to that, 75% of birthing parents who screen at risk for postpartum depression do not receive treatment. 90% of birthing parents who screen positive for substance use are not um, are not engaged in treatment either. And this directly contributes to 50% maternal mortality deaths that are related to mental health and substance use. Masitsa, you are a person who has worked hard on your recovery. And as you shared with us,
Right.
when you were pregnant, you wanted to be healthy for yourself and for your baby. When
Yes.
you look and you appreciate the percentage of women and birthing parents who are not engaged in treatment, and appreciating that nursing and medical providers have the power to engage patients in treatment, what thoughts come to mind?
I look at the numbers and I know that I was the 1 in 5 birthing parents that experienced mental health.
Mhm.
I had PTSD, I had depression, and I just know that when I spoke my concerns to them, they really took what I said and they really made me aware of, we're in this together. We can treat your mental illness and help treat, your substance abuse addiction and also help your baby. So just the providers knowing that some women are going to be going through mental illness and having us making the patient feel comfortable enough to tell their whole history. I think that would really help. I know for me it did.
Well, thank you so much. I really appreciate your strength to be vulnerable and to be also very sincere. We can also
Right.
reflect that you were one of 5 birthing parents and now you are healthy. And if we do not
Yes.
treat mental health or substance use, we can also appreciate the big financial burden in addition to compromised outcomes for birthing parents and neonates. The next slide will also talk about our truth that addiction does not just happen. The disease drives the behavior, not the other way around, as we heard from Masitza. A woman with opiate use disorder has a lot of shame and guilt. She fears stigma, judgment, and legal repercussions. When I see a face of a vulnerable woman who comes with opiate withdrawal symptoms, as a provider, I start by thanking her for seeking medical care. I listen and empathize. I validate that it is hard and also incredibly brave to reach out for help. And I thank her for her courage and strength. I ask for permission to offer help and to support in ways that she can guide me. And I also try not to be a person who is a medical provider who prescribes medication, but mostly I strive to be a healer. It is also unethical and cruel to make women feel punished for the chronic illness of substance use disorder. If we advance the next slide, we also would like to talk with you about another myth that addiction is a choice. And I'm going to ask Mositza in a minute to share what she thinks, because we do live in a world where stigma and poor awareness of substance use disorder and punitive policies of maternal opioid use create that false impression that addiction is a choice. And as you can see, there is a strong relationship between trauma, adverse childhood experiences, lack of social support, high risk behaviors, and addiction. Masitza, how does this slide resonate with you?
Yeah, so, right away, I feel like, and I know from experience that addiction was not a choice for me. This is something that I would not wish on anybody. And, I was pregnant and I still didn't want it, but I was sick. I had an illness and I needed proper treatment to get better for myself and for my unborn child. And, like I said in the past, trauma and PTSD and depression is what led me to self medicate. And being able to open up and share my history with the providers, I believe that that's what really led me to see, the truth about it all. Like, okay, this is not my fault. I didn't choose this. But because I had these things happen to me, this is the reason why, I ended up like that. But, now I'm a strong survivor. I've beat my addiction, and I'm just proud to be sitting here today.
Well, thank you for sharing. And I also am grateful that we talk about trauma. Let's open the next slide. And what is trauma? Trauma is an extremely upsetting event that could be single or repetitive, interfering with your whole well being and also contributing to poor health, substance use, and social dysfunction. I also would like to talk a little bit more about adverse childhood experiences, and let's advance the next slide. We can appreciate the importance of adverse childhood experiences and how past exposure to adverse conditions and maltreatment can compromise later life health and well being. I hope that you have heard about the ACE study. This was a collaboration between the Centers for Disease Control and Prevention and Kaiser Permanente and included more than 17,000 people. I personally every day appreciate how important it is to take careful history and discuss past exposures. And this is a factor that will really help you engage patients in treatment. And with the next slide, we can also talk a little bit more about the results of the study and how findings suggest that certain experiences, such as emotional neglect or hunger, substance use, mental health disorders, early criminal behavior, are major risk factors for the leading causes of illness and death, as well as poor quality of life. And you can here see on the slide that individuals who scored higher than 4 ACEs had 2 to 4-fold increased risk in poor health, tobacco smoking, and STIs. 4 to 12-fold risk for alcohol and other substance use disorders, in addition to the strong relationship between violence, trauma, and addiction. Now let's talk about trauma approach. And let's move to the next slide. Traditionally, the view of people seeking services is that they're sick, bad, or sick and bad. With a trauma informed perspective, we see the trauma person not as sick or bad, but just as injured. You are injured. Trauma informed care enhances a compassionate rapport building to allow each provider to create a safe space to listen, to respect, to support, and empower. And hearing from Masitza how trauma contributed to her substance use, I also would like to ask her thoughts on how trauma inspired you and empowered you to seek positive change and ultimately help.
Yes, I really do believe that going through that trauma did inspire me to seek positive change and to make a positive, healthy change for myself. Because had I not gone through that trauma, I would n- not have ended up self-medicating and not have ended up wanting to get better. So, it really was something when, like you said, you're not bad, you're not sick, you're injured. And that's true. Like, I, for such a long time, felt like I'm bad, and it's my fault. But just changing those words around to be like, you're injured, it really, really resonated with me and helped me to make those positive changes.
Well, thank you for sharing. We are learning to have trauma approach in an effort, as Masitza pointed out, to understand vulnerabilities and to support while also avoiding re-traumatization. Well, let's talk about trauma-informed care, and this would be the next slide. As a provider, I try to practice humility every day. I feel so humbled by the incredible resilience of my patients. I try to meet every birthing parent and every baby, but mostly every parent where she is. I try to change the conversation from what is wrong to what happened. And here I try to present a couple of examples for you. The first one is instead of thinking, what is wrong with this woman? How could she use drugs during pregnancy? To appreciate, I wonder what happened to this woman to affect her life this way and the impact it has had on her health and pregnancy. Masitza, would you like to help me and read the second
Mhm.
example, please?
Yes. Yes. So it's just like if a provider was to say to me, how can she use heroin and call herself a mother? I would much rather a provider say, I can appreciate the vulnerability and the courage she has to reach out for help and talk about her use. Just changing that sentence to me shows that we're on the same team, they respect me, and then I can then open up to receive the help that I need.
You value respectful communication. And if let's advance the next slide
Correct.
and let's talk about provider buy-ins and words and how words matter. And we as providers have a way of communicating that resonates with patients, like Masitza pointed out. It also impacts the response to engagement in treatment. And I try to think of a few examples of terminology to use and terminology to avoid. And also, I would like to talk a little bit more about trauma-informed communication. Let's advance to the next slide, which shares with you a little bit more about how we can establish compassionate rapport building. I usually start with offering support and validation. I ask for permission. I try to be a really good listener. That's what I tell my kids. Listen, 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 because when I listen, I create this safe space and let the birthing parent tell her story. I try to lose all labels and I also have a favorite phrase, not a whiff of judgment, which means that trying to be very respectful, to have a voice that is soft, and also to appreciate the birthing parent's experience, choices, and vulnerabilities that she presents. I also try to use motivational interviewing techniques and be very mindful to have a patient centered approach and also to emphasize autonomy, to be compassionate, to have presence, but also openness. Musitsa, you started sharing with us how important communication was for you to seek treatment and also to make you feel comfortable with the treatment that you received. How do you look at trauma informed communication?
Yes, so the trauma-informed communication I really value because it incorporates compassion, rapport building, listening, respect, support, and all of those things that we said, validating, giving space, time, and assist. Those are all things that I know because you're scared when you're going there. You know, you're unsure, you're not sure what's going to happen, and it's like you have one foot in and one foot out, and just having providers. You know, appreciate that trauma informed communication, it's everything. Words are everything. So, you know, how you say it, what you say. And I think that will help bring the other foot in and make the patient feel more comfortable in receiving that care.
Well, thank you so much for being brave to share with us. And you also reflected that moms are very scared, and sometimes being scared contributes to challenging conversations. We also have to
Right,
think about internal bias and how altogether this creates an opportunity for us as providers to really support patients no matter what. I usually try to
right,
recognize that if we have challenging conversations or behaviors that are interpreted as escalating or difficult, this could be related to trauma. And I try to attempt to process any negative past experiences. I recognize that birthing parents can also undergo traumatic childbirth if if they feel judged or shamed. And Musita, you also shared that you're a Black mother in recovery. I there is
yeah.
some evidence around pointing that Black, Indigenous, or even other birthing parents of color can experience higher rates of disrespect and maltreatment in birth that can contribute to negative encounters. How do you feel about that, Masita?
Yes, I personally had an experience, you know, after I had given birth, where I was completely judged. You know, they knew the nurse on duty knew why I was there, what I was in for. They knew my history with drugs and that I was pregnant and I had just given birth. And, you know, I had a completely just biased judgmental experience where I was crying because I was in pain and I was saying, "Can I have more pain medicine?" And, you know,
Mhm.
she was like, and I just said, "I just want to go home. I just did not feel safe there." And she would say, "Well, why would you want to go home? You should stay here. We have the good stuff here, you know." And I was just thinking, wow, you know, is it the color of my skin? Is it what I've just been through? And at that time, I just really had to pull it together and be strong. And then Dr. Rudolph came and saved the day and got me the medication that I needed. And you know, she got me scared away and I felt more respected and comfortable. But in that moment in time, I just felt all of those negative biased feelings and I felt ashamed. And it's something that I do not want any of my other, you know, Black women or Indigenous or minorities to go through, you know. So it's something that is very real because I've lived through it.
Wow, Masita, thank you for sharing. So you did have this experience that you still remember. And as a person who, just required pain medication, this made you very sensitive when you ask for help. And I also try to remember that we as providers try to offer comforting and positive regard. And sometimes, even though we have best and good intentions, we don't know how to word and communicate it. And what I hear from you is that you did feel judged. You thought that this was also maybe related to the color of your skin. And now you're here teaching us how potentially we can improve our care and think of internal bias and evaluate our role as a provider, to reflect on how our role as a healer or what you bring to the interaction with the patient. And I agree with you that we have to be very cognizant of past experience, race, religion, internal bias, and how we can learn to support patients who are very, very vulnerable. So thank you for being so brave to share with us this moment. And I also heard that when you were able to express your concerns, we learned from this experience, and you were able to improve the pain, and you received the medication.
Yes. Mhm. Yes.
So maybe you can share with us, as a medical provider, also a nursing provider, what language would have been useful for you to hear, and how could we have supported you to feel more comfortable? Is it
Yes.
okay that I'm asking?
Yes, of course. So in that situation, when I would have said, I'm in a lot of pain. I just had given birth. I really need some help. I would have preferred the nurse to say, okay, how much pain are you in? Let me see what I can do to make you feel more comfortable. And just even reassuring me, like everything's going to be okay. Just hold your baby, stare into your baby's eyes, feel that mother's love, and I'll be right back. Let me see what I can do. She would have even redirected my thoughts from my pain onto my baby. That could have helped me, because there's a strong desire with mother's love and baby's love for healing. She didn't do that. Just redirecting me would have worked, reassuring me using positive words and saying that she understands and that she'll see what she can do for help. That would have helped me a lot.
Masitso, thank you for sharing. On the one hand, this experience was painful for you and made you very vulnerable. On another hand, you are able now to share about something that felt very personal, and we can all learn
Right.
from this experience how we can cultivate genuine compassion and how we can support patients. Well, let's advance to the next slide, which actually talks about challenging conversations and how we can look at them as opportunities. And let's advance one more slide. Thank you. As Masitsa pointed out, validating vulnerability and motivation for safe birthing experience and postpartum experience is essential. And here I'd like to share with you 4 ways that I personally try to de-escalate. I use a lot of positive reward and positive redirection in my communication. And I focus on empathy and compassionate approach towards any patient. And I love cuddling babies. I usually request for permission. I try to use non-judgmental approach to effectively engage in therapeutic conversation. And something else that helps me is identifying common goals, trying to listen with compassion to build trust and effective supportive relationship. And with my communication, I usually strive to create a safe space that could potentially be even using a safe grounding technique or using a positive redirection technique. Masitsa, what communication skills do you value in the nurses that helped you to feel comfortable with the experience? We heard something that made you uncomfortable that we are learning from. I wonder um, what kind of values and what experiences did you have when you stayed on the postpartum floor that made you appreciate the nurses and their support? Can I ask?
Oh, yes. I was able to, because of you, Dr. Rudolph, room in for 5 days extra, and I was able to get the attention and the support that I needed. They would round on me constantly. They were helped me introduce me to skin. I was able to breastfeed, and I was able to ask questions that I needed to ask and to get support that I needed. Because I was a brand new mom and I was like just scared of going home. So having to stay those extra days really helped. Having them just be positive towards me, setting up for the future. Like I remember I was able to get the birth control put in, and that made me feel confident about my future. I was able to get like tobacco cessations. I was able to just really get guidance from the nurses. And I always remember that experience of being something that I'd never experienced before and thinking there's women like me that should benefit from this also. And I know that's something that you're worked on and it's something that you're working hard on. And I really do appreciate that because I think having that time in that room was valuable for, being positive and affirmations and being listened to.
Mositza, thank you so much for sharing. I also heard that while you were allowed to stay longer with your baby, and I actually will talk a little bit more about it. It's a very unique model that we started at Swedish that now we will implement across Washington. But before that, I just want to point out some of the things that you shared with us. You appreciated that you were able to ask questions and that the nursing providers and also
Mhm.
the providers were listening. And let's advance to the next slide,
Yeah.
which can show you how sometimes we engage in challenging conversations and we can redirect positively only by listening. And Masitsa felt like she was listened to and she was being understood with everything that she was asking for. And we can appreciate that you mentioned you were able to stay with your baby, you were able to breastfeed, you practice tobacco cessation, you also had a long-acting contraception, which I remember I personally placed, and it's an Nexplanon. And you felt very
Yep.
comfortable with the care that you received and all the nursing providers, which bring me to the point of how we listen to our patients. And these are three main listening skills that I personally practice. The first one is giving you your full physical and mental attention. So being completely attending in your listening. And then making sure that you are engaged with a good eye contact and that you're following. And the last one is reflecting, paraphrasing or summarizing, reflecting, and making sure that just you appreciate and you use the feelings of the birthing parent, and then you really understand what they're going through. So sometimes I would use statements that will help patients appreciate and know that I listen and I'm present, and I can say something like, "Thank you for your trust in me to share how you feel," or "I hope to support you in the ways you guide me, and I'm asking for your help to let me know what needs you have." Or I would say something like, "I appreciate your courage to come to the hospital and to ask for help. I know that this is not easy. It's also incredibly brave." By putting myself up front and asking for permission and trying to be respectful, I also engage the birthing parent and the patient in a team shared approach, and I try to find common ground. Well, let's advance to the next slide. And these are some of the things that Mosica started reflected on. At Swedish, our addiction team has continued to build ways for health equity and no wrong door services. And I know that the UDAP and Children's are as passionate as we are on this. So we stress on provider, nursing, and staff wellness as a priority to facilitate whole person care to patients and caregivers. We also try to foster support, education, we embrace individual values, and we are working value based frameworks to really improve outcomes and support patients. If we advance the next slide, I wanted to share with you that a couple of years ago, we started a wellness project at our addiction recovery services, and we included counselors, nurses, and also medical providers, the physicians. We would do huddles every month. I personally started Berry Wednesday. So every Wednesday, I buy fresh berries, blueberries,
Mhm.
strawberries, raspberries. I pay out of my pocket. We were not able to finance that And it's totally worth it because everybody loves it. And whenever we have a Wednesday, people know that we have fresh antioxidants and fruits, and it creates this community, just build up feeling. We also do interdisciplinary walks. We walk the talk and we go around the campus, and we usually would have a nurse or medical provider or a counselors or all together, and we try to socialize. We practice gratitude. We have started mindfulness. We also practice positive psychology, and we do daily reflections, and we started anti-racism workshops. So as a team, even though we have COVID pandemic, we are continuing to stay strong and stay connected. We also are setting healthy expectations and
Mhm.
boundaries, not to text after work hours and not to log in Epic, and all of us know that this is really hard to do. So if we advance the next couple of slides, I wanted to share with you. These are results from the medical providers. We also have the same results for nurses and for counselors. And we found that with focusing on burnout prevention, secondary trauma, wellness, we improved wellness by 50%, and people really felt happier. Now, let's talk a little bit more about provider support and education. If we advance the next slide, we will see that having a strong focus on education and outreach is essential. 5 years ago, we created the Provider Attitudes tool that has allowed us to look into stigma, compassion, knowledge, comfort level of care, and referral to treatment. We developed it in 2016, and whenever we organize and engage in CME and educational activities, we usually would do a pre and post intervention and qualitative and quantitative assessment. And these are a few of the examples for state and national conferences that we have organized. And at the end, I would like you to appreciate the potential of education, compassionate education. As you can see, we have been able to improve stigma by 13%, compassion by 14%, providers increase in knowledge by 31%. This is just incredible. Also, improved comfort level of care and referral to treatment, and ultimately provider attitude scores. Let's advance to the next slide.
Mhm.
It talks a little bit more about our education efforts and how it has allowed us to build community connection and to foster compassionate provider support. We recently also developed a trauma informed and provider wellness tool that we can share with all of you. And I wanted to ask Masica, as a person and a mom in recovery, how do you practice wellness?
Yes, so I practice wellness with, I recently started going to physical therapy because I was carrying a lot of tension in my shoulders. And so just going to my physical therapy twice a week helps me release all that tension and, having good posture, putting my shoulders back, sitting up straight. That really has helped me a lot. And I also take time to exercise. I recently joined the gym, so I've been exercising, eating healthier. I take walks with my daughter around the block. Just getting that fresh air has really helped. Also, to continue with my sobriety, when I can, I join the group meetings that we have on Mondays. Or excuse me, on Fridays when I can. And I also have therapy sessions about once a month with a therapist. So I still stay engaged, with sobriety, and I still do those wellness things with my children and with myself, just so I can have self-care days too and practice wellness. That helps me a lot.
Masica, thank you for sharing. And when you look at the slide about provider support and education, I wonder what thoughts you would like to share with us about providers who are educated on substance use and how this directly correlates with treatment.
Yeah, so I think when they providers are educated on it, helps them give them a broader, you know, like situation or experience about how like especially for me, like having me speak, you can see what it takes for me coming here and being open. And I think listening to my story, listening to other patients' stories, it will help because it's real situations. And I think we can learn from each other. So, the providers can learn from the patients and the patients can learn from the providers. And I think continuing to have like patients, educate providers, I think that will go a long way because it can in the long run help other women like me that were in that situation and also help the providers. So,
Well, Masita,
yeah.
thank you for your courage to share with us so we can learn from you. Let's advance the next slide. And this is our next myth that we would like to talk with you. A lot of women are scared um, to seek treatment. A lot of women actually never do while they are pregnant. And sometimes they come at the end of pregnancy and they would say, all I need is detox. I don't want my baby born addicted. We see pregnant women feeling criminalized, and it's heartbreaking. They feel coerced to go through withdrawal without getting any treatment, and sometimes providers do not know about it, which helps us appreciate that providers have a special nurturing role to help and discuss the chronic nature of opiate use disorder and how it needs timely evaluation and treatment the same way that other chronic diseases like heart disease and diabetes do. It's also incredibly important for us to reassure every birthing parent that having the chronic disease of opiate use disorder and stabilizing on a medication will not make your baby born addicted. Masitsa, what do you think about it?
Yes, I know when I came, I knew to the program, I knew nothing about, what I was going into. I had never done anything like this in my life. So to be educated that my baby would be okay, I can be on, methadone or the buprenorphine, and my baby would be born just fine. And another thing is that you guys were able to do ultrasound. So I was able to see my baby thriving and growing. And that to me was very reassuring. And when I did give birth, and even afterwards, when I was still on my medication, she has grown and thrived. And so I am a big advocate on medication, management while pregnant and even afterwards. It's something that has helped me. It's something that has continued to help me. And educating, patients on it is something that I knew I needed because some women, they don't may not know. They may be scared and think, oh, my baby may be born, addicted. I just want to go through detox. So having that um, open conversation and educating them, like what happens when I to the program, was very helpful.
Well, thank you for your strength to share with us. If we advance the next slide, we will see a little bit more about screening for substance use. I personally see um, acutely sick birthing parents who come and who are very sick from withdrawal. And I can appreciate, as Masitsa pointed out, that withdrawal could be very scary. And I usually remember that the mom is more scared than I am. And whenever I feel so scared as a provider, I try to take a step back, to take a deep breath, and just to be reminded that I'm presented with an opportunity to facilitate kind, compassionate, and diligent care, to encourage any mother to engage in treatment. And these are really good screening tools for you to appreciate. Now let's talk about evidence-based treatment and advance the next slide. As Masitsa pointed out, we encourage evidence-based treatment. I also would like to share with you that nursing providers play such a key role in creating a peaceful, safe environment that is encouraging medical adherence and also encouraging parenting skills. Nurses are the first face that birthing parents see on admission or also after delivery. Any patient can appreciate kind and caring environment that nurses create for them. I also witnessed the wonders that nurses' compassion contributes to. It inspires all of us as providers to be very gracious and supportive, and it allows and inspires women to appreciate the collaborative effort that nurses contribute to. Masitsa, can you share with us any values and qualities you appreciate in nursing providers that have helped you with just giving the medications on your road to recovery when you were admitted to our program?
Hmm. Yes, when I was admitted to the program, I know I had started on the methadone, and I they allowed me to say, I'm not comfortable with this. At first, I wanted to switch to the Subutex, and they really listened to me, and they allowed me to go through that process of switching to the Subutex because I felt like it would be better for me and my unborn baby in the long run. And I really appreciated that they let me have a voice, and they let me, they also educated me, and I was safe and comfortable. So I really did appreciate that because I said, wow, they're really taking the time to listen and let me decide for my care that this is not what I want, but I wanted this instead. And so I always remember that. I remember it felt so much better when I had switched to the Subutex. I just was feeling a lot better and a lot better about going through it with my pregnancy. So I think that just in the treatment, when I was in the program, having the nurses listen to me again, like I had stated with communication and not only listening, but executing what I said I needed. So that was something that was really good.
I really appreciate you sharing with us. You were started on one medication and then you were able to transition to another. And we do have the protocols to share how we transition from methadone to buprenorphine. We can also appreciate that being on a medication for opiate use disorder reports very similar success rates to other chronic diseases such as asthma and diabetes. Let's advance the next slide, which talks a little bit more about the two medications. And I'd like to highlight the importance of treatment. We do see birthing parents who present to the labor and delivery department with contractions, complications, and in labor that are directly related to the need of opiate withdrawal management. Medication for opiate use disorder such as methadone and buprenorphine, as you can see, it is the evidence-based treatment and also the standard of care. Therapy decision of which one to pursue when you have a sick birthing parents could be complex and individualized with multiple factors weighing in. Let's go to the next slide. And I'd like to give you a little bit more information about both medications, methadone, buprenorphine, which are used as FDA approved medications. And we as physicians evaluate the patient and order the medications. But also, I'd like to stress the importance of the nurses who have the healing power to connect with the patients while giving the medications. And even though we prescribe it, as physicians, the compassionate and non judgmental nursing care encourages birthing parents to adhere to recommendations and to take their medications. If we go to the next slide, here are a little bit more pros and cons, which medication you would like potentially to start and how you can prioritize them. And I also was hoping to share with you that recently we have been seeing an increased number of patients presenting to the hospital at the end of their pregnancy, and they are in labor without any prenatal care. And usually, this is directly related to shame and guilt and stigma. And I have found that hospital stays are wonderful opportunities to engage pregnant women with limited care because this is an essential time for us in various situations to allow us to timely provide obstetrical, mental health, treatment evaluations, to plug patient into the system and to further optimize coordinated care. We talk about smoking cessation, not only medication stabilization for opiate use disorder or substance use, but also mental health, counseling, overdose, SI prevention. And one of the most common questions that I get asked, if we advance the next slide, whenever I treat with evidence-based medication for opiate use disorder, the question is, can I get um, can I get a consent to breastfeed? Is it okay for me to breastfeed? Is it recommended? And the big question is, do we recommend moms on methadone and buprenorphine to breastfeed? The answer is absolutely yes. You have a birthing parent who admits to your floor with a newborn and receives a medication with opiate use disorder. She wants the best for her child, and she is looking for help and support. The first thing, again, that she sees is the face of a nursing provider. And all of you can provide evidence based recommendations that it is safe to breastfeed. As a matter of fact, newborns ingest a very minimal amount of mom's maintenance medication if this is something that, just worries you. Masica, you shared that you were breastfeeding. Would you like to tell us a little bit more about your experience?
Yeah, so I experienced after I had given birth to Nala, the nurses there really educated me on having Nala latch on, and they said, it's okay to breastfeed because of course I was worried, but they said, no, no, it's okay to breastfeed. We encourage it, and I'm a big advocate on breastfeeding. I believe that mother's love is, the best medicine. So I'm a big advocate for it. I promote it, and like Dr. Rudolph said, it's encouraged.
Well, thank you, Masica, for sharing with us. If we advance the next slide, I'd like to share with you how much we strive to improve access to treatment and to engage in compassionate, longitudinal, and comprehensive care that is racially equitable for everyone. We do have a Center of Excellence, and for the past few years, we have been acknowledged as the Washington Center of Excellence, offering innovative, value based models and also care that is patient centered and whole person. And we are looking forward to partner and collaborate with anyone who is as passionate as we are. Let's advance the next slide and talk a little bit more about neonatal opiate withdrawal syndrome. It also, another name is neonatal abstinence syndrome, even though the neonatal opioid withdrawal syndrome directly relates only to opioids. It occurs if you have exposure in utero, exposure to opiates, and these are the opiates that potentially can contribute to that. I have talked a little bit more about opiate withdrawal, and on this slide you can see a little bit more how we have continued to see increase in the United States that is directly related to the increase in illicit opioids and also increase in NOS rates. And I see that we are 155, so we will try to be very, very fast. Let's talk about the Finnegan scoring that was invented by Loretta Finnegan, 1974. As you can see, a lot of symptoms. The rationale for using a score-based approach for medication initiation and titration is not scientifically validated. And if we go to the next slide, we can talk about a new approach that was developed by Matthew Grossman and his Yale team in 2018. This model focuses on the baby and monitors how the baby is behaving to determine whether the baby should be transitioned to a pharmacotherapy protocol. And critically, it also encourages mom and baby to stay together. The new approach narrows assessments to only the infant's basic functions of eating, sleeping, and their ability to be consoled. The approach avoids the routine transfer to the NICU and maximizes also non-pharmacological treatment while stressing mom's role whenever possible, how she can console her baby. And they also evaluated initial data. And what they found is that in Yale, the hospital stay from 22.4 days decreased to 5.9 days. They also had a decrease in morphine treatment from 98 percentile to 14 percentile. Let's advance the next slide, which talks about the three main areas of eat, sleep, console. As this new approach is being implemented in hospital across the state of Washington, and we are very proud also to share with you that we are one of the Eat Sleep Console leaders. There is also an exciting potential to improve mom-infant bonding, decrease hospital length of stay, and decrease infant medication exposure. Let's advance the next slide. And as Eat Sleep Console is implemented, I would think that vigilance is needed to ensure adequate education for both birthing parents but also healthcare providers. Treatment for the baby ideally needs to start before delivery by empowering mothers with training and techniques to care for, just her baby that might be withdrawing. And with any change, continuous quality improvement is needed to track neonatal outcomes. We also are very excited to share with you about a model of care that we implemented a few years ago. At Swedish, we have been using an innovative approach for moms and babies that we started our advocacy with the state in 2016. We attended statewide meetings with the HCA and Department of Health, and we advocated focus not only on the baby, but we advocated for a focus on the mom, baby, and the family as one unit. And our goal was to offer zero separation and to compassionately normalize the labor and the postpartum stay for birthing parents, their infants, and also the whole family. So, what we do is we offer whole person care that is patient centered, one patient at a time. We worked to improve the pathway at the end of 2018. And in 2019, we created a compassion model that offers comprehensive, equitable care that is culturally sensitive, non judgmental, and compassionate, and starts prior to, during the admission, and involves 5-day postpartum floor stay, where we focus on the mom, the baby, and the whole family. We also focus on the nurses, so we provide 24-hour support for our nurses. It's really amazing. Let's advance the next slide. So our compassion model, compassion stands for Community of Maternal Parenting Support for Substance Impacted Women and Newborns. It's a 5-day extended postpartum floor stay for moms, birthing parents, babies, and their family members. And we have initial data to show you that when we focus not only on the baby, but we focus on the whole unit, we decrease the NICU length of stay. We also improve outcomes. And as you can see here with the data, it's quite striking to show you that only minimal amount of babies developed NOWS and needed treatment. And only, when moms and babies stayed with their parents, they were allowed to engage in follow-up treatment, and moms also were allowed to parent their babies. Now, I'd like to invite Masica to share about her experience with this, and let's advance to the next slide.
Yes, I know that when you let me stay on the postpartum floor for those increased days, that was where I really got to appreciate all of the providers and the nurses. Honestly, they showed so much compassion and caring, and I was able to see my baby thrive. I was able to learn about so much with breastfeeding and skin to skin and the tobacco cessation and just learning how to care for my baby. So I really value that. And I know you're working hard on having that implemented in other clinics and hospitals. And I think that's just wonderful.
Thank you for sharing, Masica. And we have some great news that now we are working with the Department of Health and the Healthcare Authority to implement this model and offer it to any health system, whoever is interested in that. And the next slide shows a little bit more about our services, and then our take-home points are just very simple, and we would like to foster no wrong door, whole person care. And I'm gonna ask Masica to finish our presentation because she is the patient voice and the most important person here today. Is it
Yeah.
okay, Masica?
Yes, of course. Yes, I just want to say, it takes a village for all of us to just come together and help everyone out. Like I said earlier, we can all learn from each other. The patients can learn from providers, providers can learn from patients. And I just know that we can all lift each other up and that we can do this. It's always been our saying that, can we do this? And we all say, yes, we can. So I believe that we can do this. So thank you for having me.
Yes, we can. Thank you so much, Masita, for
Thank you.
presenting. And thank you all for having us.